Module K, restraint elimination, reduction, and appropriate use. We're going to be talking about the different types of restraints that you may see being used in healthcare. We're going to talk about the risks that can arise when we use restraints, how the need for restraints and laws both regulate their use. We're going to talk about residents' rights and our role as nurse aides, and the importance of safe application and the need for really close observation if we do have a resident or patient who is in restraints. You're going to hear the term restraint-free care, and that is basically an environment in which restraints are not kept or used for any reason. A lot of nursing homes and long-term care facilities are restraint-free. So again, you won't see any restraints in these types of settings. Restraint alternatives are basically any measure that we can use instead of a physical or chemical restraint. And we're going to talk about what some of those alternatives are. So restraints can be chemical, physical, or mechanical. And it's basically a method used to restrict freedom of movement or normal access to one's body. A chemical restraint is any drug or drug dose that is used to control behavior or restrict movement. A physical restraint is any manual method, physical or mechanical, device, material, or equipment attached to or near an individual that cannot be removed easily and restricts freedom of movement or normal access to one's body. And we talked about that a little bit in class when we said that different objects can be used as restraints that you might not normally think of. And we're going to talk about these in a minute here, but an example would be that bed over table. If you put it in such a position that it makes a person not able to move freely or get up out of bed, then it's considered a restraint. There are actually cloth and leather restraints or mesh sometimes. Most often you're going to see the cloth or mesh. Leather restraints are used for extreme agitation and combativeness, and those are applied on the wrists and ankles. Facilities have practices that are considered forms of restraints, and this is what I was talking about. Side rails, if they're used to keep residents from voluntarily getting out of bed, are considered restraints. If you tuck in or use Velcro to hold sheets, fabric, or clothing tightly in such a way that it restricts movement, that's a restraint. If you place a resident in a chair like a Jerry chair, and you may not be familiar with those yet, but the Jerry chairs are like a recliner, so you can lean them back. So if a patient is placed in a Jerry chair and leaned back so that they cannot get up on their own, that's a restraint. Placing a chair or bed so close to the wall that it prevents them from getting out of bed, also a restraint. Placing a walker out of reach to discourage independence, also a restraint. So be aware of ways that residents may be restrained and be careful about that. So let's see. Using restraints can result in injuries or sometimes even death. Residents who are in restraints can get cuts, bruises, skin tears, skin breakdown and pressure ulcers, sometimes fractures. People in restraints can choke and aspirate or strangulate to death. Constipation, contractures, dehydration and incontinence, pneumonia, urinary tract infections. These are all things that can happen when someone is in restraints. Edema, swelling, nerve damage, mental health issues. I mean, could you imagine, right? Agitation, anger, delirium and depression, withdrawal, and of course, self-esteem issues as well. Embarrassment, humiliation, loss of dignity, loss of confidence and self-worth. So if we have a patient or a resident who has been in or is in restraints, we want to make sure that we understand the reason for the restraints. And part of that is to make sure that it's, understand why it's appropriate, and question it if we don't think it is. We want to consider how the following may influence the decision to use restraints. So pain, mental, physical illness and impairment, injury and discomfort, uncomfortable clothing, wounds dressings, anger, loss. There's phobias, obsessions, sleep disorders, confusion and disorientation, hunger and thirst. All of these could lead, and I have to be careful how I say this, could lead to behaviors that may need restraints, but this is only when we have done all restraint alternatives and all other options have been looked at. So let's talk about some of those as well in a minute. But before we get to that, we're going to talk about federal and state laws. So federal and state laws are in place to protect residents, right? Accrediting agencies help oversee and enforce these laws. And that list right there is just an example of some of the different agencies that do this. The laws are meant to protect and can't be enforced if we're not reporting if we see something wrong. And the reason that's in here is because if you, let's say, work in a facility and you see the Jerry chairs being used inappropriately, well, we need to make sure that we're upholding the laws and reporting those or doing something about it. The resident has a right to be free any physical or chemical restraint that's imposed for the purposes of discipline or convenience and not required to treat the resident's medical symptoms. Unnecessary restraints are false imprisonment. And so, again, it's really important to know what can be considered restraint. And that list that was back there that said some of the situations that could lead to restraint use, it's really important to have an understanding of those and think about how could those lead to restraint use and how can we prevent getting to that point, right? So there is very strict criteria for the use of restraints. A restraint must be used to protect someone, okay? Again, it's not ever used to make your job easier. It's used to protect someone. A doctor's order is required, and those doctor's orders have to be renewed every 24 hours. So restraints are only used if measures fail to protect, any other measures that we've tried have failed to protect the resident. It also states that we have to use the least restrictive method first. We must get informed consent, and that could be from the resident or a designated legal representative. And residents must be monitored for their vital signs, respiratory status, and dehydration. As the nurse aide, we always, of course, are following the nursing care plan. Whenever possible, when working with a resident or a patient who is in restraints, we want to schedule care to align with the resident's typical routines and preferences. And we want to consider the resident's needs based on Maslow's hierarchy of needs. So again, our priorities are going to be making sure to meet the physiological needs of our resident. That's the primary thing that has to be met first. So that's nutrition, elimination, breathing, sleep, and exercise. So again, sticking as closely with as we can to how, the regular schedule and routine. When someone's in restraints, we need to take time with meals, continue to encourage fluids and assist with fluids, bathing, bathroom, hygiene, allowing time for bathing and grooming, making them as comfortable as possible in their bed, their chair, using pillows. Whenever there is an item in reach that they can have, make sure it's accessible. And then reduce or eliminate noise, odor, or other distractions. When we get to the next level of Maslow's hierarchy of needs, we're talking about safety and security. And you want to remember this number right here. So if you have a resident who is in restraints, healthcare provider has to check on that resident every 15 minutes or more often. So write that down. Every 15 minutes or more often, you have to be checking on your resident. Of course, when we're talking about safety, you guys are familiar with this now. Positioning the bed at the lowest height, making sure wheels are locked. Sometimes you'll be placing cushions next to the floor if needed. Removing or relocating furniture with sharp corners, because if someone's in restraints, if they were to twist or turn or, hopefully not, if they were to fall or slip, you just don't want them hurting themselves. We want to make sure that the call bell is still within reach and accessible, and be attentive to their feet because this is a scary thing. It's scary to be in restraints. So make sure that we're addressing those fears as well. Of course, it's always important to report accurately and promptly any concerns that we see or hear or that the resident expresses to us. So love and belonging is the next step up on Maslow's hierarchy of needs. So our residents in restraints, they may not be interacting right as much with others as they were before. So we want to make sure to spend time with the resident, encourage conversation. If they're able to go for a walk with the resident, having some distractions like TV or a book or a game, and then really encouraging family and friends to visit, or maybe they like having clergy members visit. Self-esteem and self-actualization, that's that very top of that pyramid. Encourage the resident, compliment and reassure them, help them to feel safe, comfortable, and try and maintain as much dignity as possible. When someone is in restraint, safety is, of course, the highest priority. So restraints have to be applied properly. We have to check the size and the condition of the restraint and ensure that they are fastened correctly and securely. And we want them fastened securely, but of course, and we'll talk about this in a minute, we have to make sure that it doesn't restrict any circulation or the ability to breathe fully, anything like that. We want to secure straps out of the person's reach and secure the restraint so that let's say if you were to tie a restraint to a bed rail and then someone moved the bed rail, well, that would change the tightness of that restraint and could be dangerous. So be careful where you're attaching your restraints as well. When we're attaching or applying, I should say, restraints, we always want to leave 1 to 2 inches of slack in the straps to allow for some movement to that or of that part of the body, unless we're instructed to do otherwise. So an example of that would be, if someone's having to be in a wrist restraint because they continuously pull out a tube or mess with a wound, we want to leave some slack, but not enough to where they can continue messing with that wound or pulling at that tube. We want to make sure to pad bony areas to prevent pressure sores. And this is another important one that you have to remember. Oh, right there it is. So we already know that we have to observe our resident in restraints at least every 15 minutes. We also have to remove the restraint, so take it off, and reposition the resident and attend to all of those basic needs, so like going to the bathroom, food, water, hygiene, etc., at least every 2 hours for at least 10 minutes, or more often if in a care plan. So again, someone in restraints, every 2 hours, we have to take that restraint off for a minimum of 10 minutes, and then we put it back on. We want to monitor vital signs of our residents in restraints and help them by performing range of motion exercises like we've learned in class. Let's see. Okay, so there are a variety of different kinds of restraints. There's leg and ankle restraints, there's hand mitts, there's wrist restraints, seat belt restraints, there's vests. So leg and ankle restraints, of course, are going to limit the mobility of the leg and ankle. We need to allow at least 1 finger between the leg and the restraint. Arm, of course, limiting mobility of your arm, again, as long as there's about 1 finger between the restraint and the body. Hand mitts, those are probably the ones I most commonly use, the hand mitts and the ankle and the wrist restraints. Hand mitts just limit the mobility of the hand, so they can still move their arms pretty freely or if not totally freely, but they just can't use their hands. So this is great for patients who just may be a little bit confused and disoriented and you don't want them pulling out tubes or messing with an injury. Again, should allow about 1 finger between the wrist and the restraint. Wrist restraints, this is an example right there, limits movement, prevents pulling of tubes or medical devices or scratching at wounds. The soft part, of course, is going to go next to the skin, and 1 finger in between is a good spacing or a good tightness. The seatbelt restraints, these help to reduce falls while sitting, should be placed at a 45-degree angle over the thighs. residents' hips, just like we learned in that skill when we transfer from bed to wheelchair, if someone's in a chair, their hips need to be at the back of the chair. And this is going to allow the resident a seatbelt allows them still to kind of turn side to side or even obviously be in a sitting position, but limits falling. I mentioned that we have different jackets or vests as well. This is, of course, to limit the mobility of the upper body. These should be snug, but they should allow the resident to breathe easily. Usually, if you can fit one flat hand between the body and the vest or jacket, that's good. This is an example of one type of vest. This is a V-front vest. Again, it should be snug, but same as with the other types of jackets, should allow the resident to breathe easily with the flat hand in between. All right, so this is kind of jumping back to some of these things that can be considered restraints. Lat trays, they can help prevent a resident from leaning forward or falling out of the chair. But again, if we use them as a restraint, we have to make sure that we have an order for that, right? Same with the side rails. They can be used as a restraint, but again, we have to make sure that that's been in order, and all other alternatives have been tried. Facilities may unintentionally use methods to help ensure resident safety, which may be viewed as restraints, which we've just talked about. It's important to recognize items that can restrict residents and prevent them from being mobile. If you have a concern, communicate those concerns to the nurse in a professional manner, such as over a bed table, sheets, jerry chairs, or wheelchairs. Remember that restraints are never used as a convenience for the nursing staff or as an act of discipline or punishment. Unnecessary restraints, whether that be physical, mechanical, or chemical, are considered false imprisonment. Restraints are used as a last resort intended to protect the welfare and safety of the resident and others. Restraints take away a resident's right to freedom, and it violates their right to be treated with respect and dignity. Restraints require a doctor's order, and always ask for clarification before applying a restraint yourself. Be patient, kind, and empathetic to those who are in restraints.